and specifically what master's in social work or a bachelor's in mental health counseling or psychology. And then if you're also able to put in what university. So just the degree you're seeking, and then also the university. If you could put that into the chat just so we know who is joining. Awesome. Really spread out here across the country. So very interesting. For those of you who just joined, just giving everyone a heads up that the panel will actually start at 5:45. Apologies in advance. We did try to send out communication, and some of you have gotten that, and some of you have not. Have not. Unfortunately, the panel will start at 5:45. In the meantime, everyone is just putting into the chat the degree that they are seeking, and the university that they're currently going to. And in another second, we'll also reach out to the people who came in here early, and we'll get some of your questions for the panel. We do have some questions for the panel already prepared, but would love to know what you would like to hear. So if you also want to start putting that into the chat, what specific questions you have for the panel. Again, these are, master's level, have graduated with a master's degree, are currently registered in the state of Florida working towards their licensure individuals, working as a full-time therapist. So any specific questions you have for them, please feel free to put that into the chat. And we may even use some of your questions as opposed to our questions if we're seeing some themes in there as well. So for those of you who just joined, we will be starting the panel at 5:45. Apologize about the confusion. We did send an email out. I'm not sure if all of you have, clearly not all of you have gotten it. In the interim, what we're doing is we're just putting into the chat the degree that you're currently seeking, and from which university. And if you want to go ahead and also put questions that you have specifically for the panel, feel free to do that now. We do have questions, and we do leave time at the end for frequently asked questions. But if there is anything that you have specifically, please let us know. The panel will run from 5:45 p.m. to 6:45 p.m. But again, you're free to join or leave whenever you need to. We do have a recording as well that we are doing for those of you who have attended. Welcome for those of you who just joined. The panel will officially be starting at 5:45 p.m. In the interim, what we're doing is we're putting into the chat our degree that we're seeking and the universities that we're attending. So feel free to go ahead and put that in there. Congratulations to those who have graduated very recently, last month. So feel free to put that into the chat so we know kind of generally who's attending. It looks to be very split between bachelor's and master's level and a couple PhD. And then also any questions that you have for the panel, and you're free to do that now or throughout the presentation. We will be asking questions to the panel, and we will have a frequently asked questions section at the end. But sometimes if we see some themes and questions, we will make sure to get that in before the FAQ part. Also, while I have everybody for the next 8 minutes, we are also working on a conference. It will be a hybrid conference based out of Florida in Orlando in April of 2026. And the conference is going to be specifically geared towards soon to be graduates of a master's program. And we're in the middle right now of the development of content. And so it would be very interesting if anybody has anything specifically that they would like to know, or what would you find very valuable in a conference as it relates to in the specific field of mental health? And so some of the things we've talked about is covering imposter syndrome and prevention of burnout, working with difficult patients, but also talking about different diagnoses and modalities around that, and having some of our subject matter experts run working groups. But we'd love to know from you if there's anything specifically that you would find extremely valuable in attending a full day conference, whether it's hybrid, whether it's in person or doing remotely, and what specifically that you would find valuable in attending. What would you want to attend for? And I appreciate any feedback that you have on that. I already see some comments coming in there as well. So for those of you who just joined, just as a heads up, we will be starting the panel at 5:45. So a couple minutes here, we will go ahead and begin. Um, in the meantime, if you could go ahead and put into the chat the degree that you're seeking and the university that you're seeking it from, so we have a general idea who's attending and could try to tailor the panel questions specifically to some of those things. The other thing you could also do in the chat, if you have a specific question for the panel, you could feel free to put that in at any time. We do have questions for the panel, and we'll run about 45 minutes of questions. And then ultimately, we'll have 15 minutes at the end, 15 to 20 minutes at the end for some of your questions. But if I see themes, I do go ahead and try to pick those questions out. And then also, we are hosting a conference in April of 2026 out of Orlando, Florida. It will be both an in-person conference for those who want to attend in person, and it will be remote as well. We're currently just finalizing the content for this conference, and it is really going to be geared towards soon to be graduates of master's programs or people who just graduated with their master's in some kind of mental health related field, social work, mental health counseling, psychology, and marriage and family therapy. And so, what we'd be interested to know is what specific topics, content that you would be interested and intrigued about. We've heard everything from helping with resume writing or interviewing assistance to uh, addressing your burnout and imposter syndrome, running over specific clinical modalities. So please feel free to provide any kind of content that you would like to see or find valuable in a 1 day conference. So if you can go ahead and put that into the chat, we'll begin in just a couple moments.
Hey there, Phil. I know we haven't started yet, but I just read Andrew M's question. That was a really cool one. I have a lot of very strong opinions about AI in our profession.
Awesome. Yeah, that was actually one of the questions that I had for the panel is how they're using AI. So I was excited to see that one as well.
I think if we aren't careful, we're sleepwalking into it taking over our profession. So thank you so much for your interest, gentlemen.
Yeah, absolutely. Okay, we'll go ahead and kick it off. The two other panel members we have had, unfortunately, some patients that they were seeing, so they will be joining us here shortly. As you know, the nature of the work is uh, sometimes unpredictable, so you never know what you're going to be dealing with some of your clients. So as soon as they're able to join, we'll go ahead and join. In the interim, let me just talk quickly about the organization and the intention behind this panel, and then I'll introduce Nick, and hopefully in that time we'll have Andrea and Asia joining as well. So the name is very confusing. Confusing. Elite DNA Behavioral Health. The DNA is actually an acronym for the owner's three children, Dylan, Noah, and Asher. So Elite DNA is a Florida-based, well, excuse me, Florida and now Virginia-based outpatient mental health provider with about 37 locations across the country, about 400 therapists, and about 130 prescribers. We are owned and operated by a licensed therapist, and so it's her name is Lizzie and her husband who own the organization, and we're very big into continuing education. You may see one of the participants is called Elite DNA University, and that's actually our training platform. We do about 30 internal trainings for our therapists every single year, and we run about 4 to 6 external trainings, this being one of them every year. So we're very excited, as many of you who joined us earlier heard me talk about the conference that we're hosting. That will be our first ever conference, and that will be for external individuals like yourself who are looking to get a better grasp of what it's like when you do graduate and learning different modalities and things like that. So appreciate everyone joining us today. Let me go ahead and introduce Nick, if you want to introduce yourself, where you're located, your degree, and then we'll talk more about you in just a moment.
Sure. My name is Nick Signorile. I'm a registered mental health counseling intern, meaning I'm not fully licensed yet. I'm about a year out before I can apply for licensure. I graduated from the University of North Florida, and I love therapy.
Awesome. And I believe Andrea has not joined yet, so we'll introduce her in just a moment. So I'm interested to know from you, Nick, as we have both bachelor's level and master's levels individual here on the call. What was it specifically that led you to your master's degree? Why not a master's in social work or marriage and family therapy? And what is the difference between mental health counseling, social work, and marriage and family therapy as far as you see it in your work?
Excellent question. So, what initially drew me to the field was I always kind of had this pull towards some kind of helping profession. Biomedical stuff kind of grossed me out, so that was off the table. And once I got into psychology, got my bachelor's of psychology, I'm like, okay, I want to do something in this field. I took an intro to counseling class that was taught by an LMFT, a licensed marriage and family therapist. And he really laid out the different kinds of therapeutic providers. Um, I know that marriage and family therapists, mostly it really came down to working with multiple people at the same time. Because I'm RMHCI, I do primarily work with individuals. I find when you work with kids, you're actually working with parents, and that incorporates some family system stuff, some behavioral management stuff. So in a way, I still am kind of treating families in a way. But ultimately, I didn't want that to be my bread and butter. The thought of treating helping couples makes my eyes cross. I can barely track what one person's telling me in the room, let alone two. But aside from that, social work was on the table. But then when I got into things like case management, resource management, I love, love, love connecting my clients with local resources. But the actual like case management part of things just didn't have the same draw to me. And when I looked at the different programs in my area, UNF's programs and faculty at the time really emphasized serving LGBT and diverse populations, which was a critical interest of mine because at the time I was serving on the board of directors for a local LGBT nonprofit. And so really it was like, as corny and cheesy as it may sound, it feels like it feels like this track chose me. But it was really enriching. I'm really glad that I chose the path that I do, and the thought of working with couples still makes me my eyes want to cross.
Talk to me a little bit about why you're an outpatient, right? You work hybrid schedule in the office and remotely. Why outpatient? Why not inpatient? Why do you feel like that was the best route for you? And what is the difference for those who aren't familiar between an inpatient and outpatient position?
Sure. So inpatient, outpatient is vastly different. Inpatient usually deals with more acute conditions like very pervasive schizophrenia, active suicidal ideation, active eating disorders. Um, and when I got into therapy, I remember having a conversation with my sister, who's also a therapist. We didn't plan that, that's just how it happened. And I said, she said, well, what kind of populations do you want to work with? And this was before I really knew what that question meant. And I said, I just want to work with like everyday people. And from that, I kind of turned into, oh, I want to work outpatient. Another difference between inpatient and outpatient is the intensity and time of those sessions. Sometimes those sessions can run for multiple hours and there's group involved. And it really just felt a little more hands-on than what I wanted. Mostly because I also knew my limits. Like outpatient just may be a little too intense for me, even if it would provide some very valuable experience. I work with very talented people who actually got their start in inpatient and crisis management, and they do phenomenal work. But I think for me, I just really wanted to start and end with outpatient.
Awesome. Interested to know, and we use today as a great example. For those who aren't familiar with what a day is like for an outpatient provider, what was your day like today as far as cases, how long you see the patients, how many you saw today? Kind of walk everybody through kind of how you go about your day.
Yeah, so today was actually very nice, in the sense that everyone was great. I just had a lot of great sessions, but also today I was scheduled to work. I believe normally my days range from 8 to 5, 9 to 6, and 10 to 7, which sounds hectic. Don't worry if you're thinking about applying. Not everyone's schedule looks like that. That's just what works for me. Um, but typically, because today my first patient didn't show up, so I came in a little bit later, spent a little bit more time with my family, got to practice a little bit more self-care. But typically after that, I've had patient to patient since then, and everyone's shown up today. Typically, my day-to-day looks like, firstly, taking about 5 minutes to review a patient's chart, seeing where we left off because my caseload is a little bit high, figuring out what the next direction is going to be going in. And then typically the way I run sessions is I have a general idea of what I want to do with the patient. But I always start by asking, hey, any new business, any new major events, or is there something that's really been on your mind that you wanted to work on first? And I'll typically move through those sessions that way. Let's see. Oh, this is a big distinction. So when I'm working with adults, it's usually very, for lack of a better term, cerebral. We're working a lot on challenging thoughts. We're working a lot on how their bodies are reacting in the moments. We're working a lot on organizational skills and things like that. And because they're adults seeking services, they're generally very motivated to use those tools. I also work a lot with kids. Now, kids, if I tell them, hey, we're going to self-regulate today, they'll be like, why? I don't want to do that. So it creates a new kind of challenge for some of these kids. They may not even really want to be in therapy. And a lot of times people get frustrated by that. I love a challenge, so I love working with kids. And once we get to a place where, like all my patients I saw today, most of them were regulars. Once you get to a place where you've earned a lot of trust and you're in that place, working with kids is actually a lot of fun. It's a lot of playing pretend. It's a lot of drawing together, coloring together. One of my favorite things that I've been doing with one of my most recent patient is just been drawing Pokemon together and talking about our feelings, and that's been really wonderful for him. So day to day, it can actually look very different from what I'm doing with my patients. On the whole, though, I'm still kind of using my central modalities. I'm still using very basic CBT and grounding techniques. So that part doesn't change so much. It's just kind of like how I deliver it changes from adults to kids.
I want to, Nick, save a couple of the questions until Andrea joins. When we think about the name of this presentation, A Counselor's Daily Journey Through Healing and Hope, I want to talk about some of the mindset and how you approach difficult patients and tough cases and things like that in just a moment, just so we also have her as well as she's finishing up her patient. I do want to get to the question that I had and also Andrew had about AI. And I have my own, personal experience with AI as it relates to, professionally here, and also interactions with others who are using AI in the organization. Are you currently using AI in your day to day, and what is your general thoughts? Is AI helpful or hurtful to therapies?
So I have some mixed opinions on AI. So ChatGPT is wonderful, especially so the way I use AI is I primarily use ChatGPT and I don't really use it for interventions or things like that. I primarily use it to generate ideas for talking points on resistant patients. For example, one of my most difficult populations to work with is teenage girls. Just in my experience, they tend to be more closed off, especially because I'm a bigger guy and sometimes it takes them a while for them to warm up to me. So I'll go into chat and say, "Hey, or I know a teenager with these interests. Give me some talking points to work off of, so I can start building that rapport, and so I feel like I have more even footing on my underneath me." In terms of day-to-day AI use and other capacities, I know we do a sort of program where it's like AI note taking. It views the Zoom call and kind of consolidates a note after the fact. I'm very hesitant to use AI that way, only because if we were to use it in that capacity, I would want some kind of guarantee that the information that the AI is viewing is not being used to train itself. Meaning, I don't want our clients' information to be used to train those AI models because I feel like their information should still remain protected. If I had a clear answer to that question, I might be more likely to use it. But overall, that's been kind of my use of AI. I have some opinions on how clients use AI, but that wasn't really the question, so I'll save that for another time.
Yeah, and I think my comments, and Andrea, we'll get your comments on AI in just a second. My comments on AI, and I'm not a techie person at all. I still don't understand what the cloud is or how it works. But as it relates to AI, what we're finding is on a therapeutic level, just as Nick described, it can be very helpful in prepping and preparing for sessions, coming up with ideas. As it relates to really embracing AI, a lot of our clinicians are using AI to transcribe their notes, and it has really saved them a tremendous amount of time. Now, when we talk about transcription, we're not talking about the recording of sessions, which is extremely important, and we're not talking about the AI using any of the information, HIPAA compliant information, as we do have it on a HIPAA compliant platform and use the BAA, so everything from that standpoint is safe, but it's only uh, utilizing the information to improve upon the way that it's writing specific to that individual's flow and process. And so that has been extremely helpful. What a note can take, depending on how wordy someone can be, it could take anywhere between 7 to 10 minutes when they feel comfortable on the medical record that we use. And it's taking, a minute now. And it's really, really helping providers balance when we talk about burnout and healing. It really helps them be more present in the sessions because they don't have to worry about the taking the notes. And more importantly, they can kind of go home with the notes already completed. Now, with that being said, there's a lot of concern from an AI standpoint. I don't want to get too far off track here, but is AI or these AI CBT tools now that are having people do therapy with AI? In my conversation at an executive level with payers, with legislators, there is no immediate replacement of individual therapy with a human being. It's going to be very, very difficult from a legislative standpoint, but also from a payer standpoint, because at the end of the day, there is no when you look at any of the research done currently, there's very little. There's no efficacy on therapy that is done with an AI. Now, I think there is individuals that use AI as from a social component, and I think there's part of that is helpful for those people, but it does never replace true evidence-based therapy. And so we are not anywhere close to. I heard someone say the other day, well, if I knew AI, when I started my degree, if I knew AI was going to take off so fast, I would have got my degree in therapy. In fact, I think it's probably one of the safest positions to be in. And so I think as that relates, and not to get too far off topic, I think AI, we need to embrace it from a standpoint of it could be a tremendous help for our providers to really focus on what they do best, which is giving patient care and help them in what they hate to do, which is the notes and documentation. Andrea, anything that you want to add as far as are you using AI at all currently?
So I don't use it at all. Just not so much. I think I share some views that Nick shared, but also just personal beliefs with the environment. I'm a very earthy person, and I've seen like the environmental effects of it. So I will say that from my perspective, but I know of multiple providers in my office that use it and they speak highly of it, especially people that maybe don't see themselves as effective with their notes or they're really busy, especially like or psychiatry providers that they have a lot of appointments throughout the day. And also as a registered intern, which I also encourage people to do is like train yourself to like be a good note writer. Like sure, when you're licensed, use AI, use more of those tools. I think they're amazing for the people that really need it. But as a registered intern, like I just really want to be mindful and ethical too of like I want to learn how to write notes and do it efficiently, especially during like this educational period. With that being said, I also have heard from other people that using AI has helped them write better notes and in the sense that they've been more concise with their notes because of the tips that AI has been giving them. So I think as with everything, it's just like personal choice, but I do appreciate that is a tool being offered to us.
Awesome. Andrea, we'll stay with you here for a second before we get into some of the maybe heavy hitter questions here. If you don't mind, if you just want to introduce yourself, which office you're out of, your degree, and why you got into the field.
Yeah, so sorry I'm a little late. I was with a client. So I'm in the Venice office. I am a registered intern. I graduated from the University of North Florida with my master's in clinical mental health counseling. I actually graduated with Nick, so it's amazing to always see us like in this full circle moment of starting our program together, starting practicum together, internship, and then graduating and now being a full-time therapist. I love what I do. I was actually talking to my supervisor about this assessment. It's called the Professional Quality of Life Scale. So it just assesses for burnout and some other components of like having a healthy work-life balance. And my scores were like pretty decent. So I was satisfied with that. And again, it just reinforces that I'm in the right field. I work with all ages right now. Today was actually an interesting day because I saw my youngest, who is 7, and I saw my oldest, who is 83. So it's amazing to have that wide range of ages because I learned so much and I'm still trying to figure out what my niche is. And yeah, I've been on Elite DNA for almost a year. It'll be a year in September.
Awesome. Let's go back to Nick here, and we'll ask you both this question. So the name of the session is Beyond the Couch, a counselor's daily journey through healing and hope. And I know, and historically, we've talked in sessions a little bit about how you got into the field and cases and things like that. Really want to talk about how when we talk about healing and hope, there's always resistant patients, right? Now, even though the work that we do is voluntary, we don't do any involuntary work, meaning that we don't have anybody who's coming to us who's court ordered. Anybody who's coming to us is coming to us because they want help. Now, that doesn't necessarily mean that, if it's the child, a teenage child, and their parents are bringing them here, that they are always, fully committed. But I'd be interested to know, and we'll start with you, Nick. When you think about I'm going to call a treatment-resistant patient, someone who, maybe is not, really giving their all in the sessions, what is your mindset going into those sessions, right? How do you approach those patients, and how do you handle it when it's really not maybe going the way that you had hoped?
Yeah, so that's actually one of the things that I love about this profession and terrifies me about my work sometimes is that you really don't know what you're going to walk into day to day. And so this is going to be kind of a weird metaphor, but I almost like to treat what I do as kind of like jazz sessions. We're improvising. We're trying to figure out what can we do in the moment differently to get this person around. And a lot of times that really results in just connecting on a person to person level, shedding away the therapy, shedding away the techniques, and just being a human being with the other person in the room does so much to foster that connection. Sometimes when it comes to resistance, it's a matter of just finding common ground and building a relationship off of that. Other times it's just kind of rolling with it. And like, for example, I had a patient recently who didn't want to learn the skills. They said, I'm content just talking and venting and doing that thing too. And then they said, okay, but didn't we say we talk about this traumatic thing that happened? I said, well, we got to learn some skills before we get to that place because I'm not going to help you reprocess trauma if we're not at that place. And so we accept where they're at, we accept their limitations, but we also have to bring to their attention, look, we can't go much further if you're not willing to buy into it. Um, I'm trying to think. With kids, a lot of it comes down to trying to show them how their actions are working against their own interests. Like, okay, you really want to throw that Nerf football at your mom's head because it makes you happy and it makes you feel good, and you can't think of a good reason not to. And then I kind of bring up, well, didn't you get your Xbox taken away because of that? Didn't you lose out on a whole weekend? Didn't you do this? Didn't this happen? In a very non-judgmental way, just saying like, but what about this thing that's also happening? So that's typically my two approaches, depending on what the mood is in the room. I either kind of back off and take a more relaxed approach, or if I feel like the rapport is there, I might challenge them a little bit and say, okay, is that actually helping you or is that getting in the way more?
And in a situation, if it's not going well, maybe you had a really tough session, how do you shake that off and prepare for the next patient?
That comes down to some kind of self-care. So I can't speak for other therapists and other people in the panel, but typically there's a list of activities that I can choose from that'll help me feel more regulated and kind of distance myself from the previous session into the next one. And also with the reminder of, because we're not a crisis center, because we're not, out intensive inpatient or anything like that, typically if I need to regulate myself and their session is just 5 minutes late, it's just going to be 5 minutes late. I'm going to take that walk. I'm going to read a comic book. I'm going to do something to really distance myself from that last patient. That way I can be fully present. Because if I'm sitting there with this new patient thinking about my last one, I'm not going to be any help to anyone.
Awesome. Thank you, Nick. Andrew, let's go back to the previous question. When we talked about mindset, what is your mindset when you're approaching patients who are treatment resistant?
Yeah, I see that mainly with teens, and I honestly find it kind of fun because it's like look, I get it. Like you don't want to be here. Sometimes I don't want to be here either. Like I don't blame you. So I think it's approaching that with like unconditional positive regard. A lot of times it's a little bit more of like self-disclosure too. Like, okay, what interests do we share that we can talk about that it's not necessarily psychoeducational or I guess I think it's therapeutic, but yeah, not psychoeducational necessarily. But you can create a foundation for a relationship that is trusting. I reinforce a lot with my teens and my kids that there's going to be information that it is necessary that I share with their parents or with their guardians, but ultimately, like it is a confidential relationship. And if there's things that they need to share about their parents, about what's going on, I'm not going to divulge that information unless I have to. Um, so I think that building that foundation of trust, that relationship where we can both collaborate. A lot of times I'm like, this is for your own benefit. Sometimes I utilize silence a lot. I'm comfortable with silence, so I'm just like, okay, I'm just gonna wait here and see if you want to use this time that you have to be here for something beneficial or not. And this actually happened to me this week. I was just kind of silent, a very withdrawn teen going through a lot of things. And eventually she just starts spilling the beans. And we had a really good, I think like 45-minute session. So it's just really being patient, meeting them where they are. One of the things my supervisor reinforced that was so helpful, and I tell everyone who's just starting with this career is like, you cannot work harder than your clients. Like they, in reality, like we're there, we're providing the tools, the safe space to process different things. But at the end of the day, like they are the ones doing the hard work. So that is to say that it makes me feel better, of course, like they have to be the ones working. Um, but it's also for them, like they have to take autonomy of their healing journal. Um, so yeah, it's a little bit of everything. And for the ones that are really, really resistant, at least doing some psychoeducation during the session. Like even if they don't want to process, if they don't want to explore different things, I do want to leave them with at least something. So I just do psychoeducation for those cases, which they don't really happen a lot, but they do happen from time to time.
And when you had a really tough case, Andrea, how do you, from a mindset perspective, how do you kind of disengage and prepare for that next session?
Yeah, I would say same with Nick. Our office is, I think the space where we are is decent, is nice. So sometimes I just take a lap around our office and kind of decompress. I do some like quick little body stretches, some progressive muscle relaxation, just some grounding techniques that can help me get ready for that next session. Sometimes I do music, like if there's something new that I want to, I don't know, listen to or some relaxing, calming music, I'll do that too. So just trying to stay present and compassionate with myself too. Like at the end of the day, I am a human working with humans, so I'm gonna feel a certain type of way after some sessions. But just making sure that that is not interfering with the care of my next session or my next client.
And by nature, this is very purpose-driven work, right? Nobody gets into this field because they're money-driven. They really get into this field because they want to help people, right? So when you think about how I view it as almost like a flame, right? You graduate, you have this excitement, you're helping people. There are going to be hard times when maybe it's a tough week, maybe something happened with a patient, that was really hard to hear, or unfortunately even worse than that. And so my question is, how do you maintain that fire? We as an organization, we're very strength based, so we have a lot of high learners in the organization, and what they would say is, they take trainings, right, and that's helpful to them. And other people say they just love being around people. I guess we'll go to Andrea and then we'll go to Nick. For you both, how do you maintain that fire of really just loving what you do and keeping that excitement to want to come to work every day?
Yeah, I think that's hard, especially for our profession, because like I tell people, like a lot of times, like there's not like tangible changes. So like if you're a physical therapist, like you might see someone that comes in with, I don't know, torn ACL after surgery. And then after, I don't know, 6 months, you see them running and walking, and it's like, oh my gosh, like I did so well in this job. Like this person is now up to full functioning. And therapy, like a lot of times you don't even see those changes. Like, sure, maybe someone is improving, there's some goals that are being met, but like we can't see them as tangible as other professions. So I think like finding a little bit of comfort in like just the space that you're providing other people. Like a lot of times people don't have the space to vent, to share with someone and receive that unconditional support. Like sometimes people don't even have other someone else to talk to, someone else to support them. So I think just kind of like keeping that in mind, like I am doing something for someone, even if it's just sitting here for 53, 60 minutes. And then going back to the roots of like why I started doing the work that I do, I think even now we're seeing a lot of conflict in the world in general, a lot of people suffering, and that is initially what led me to what I do right now. Um, so understanding that like 14-year-old version of me will be so proud of what I'm doing. And that also really keeps me going because I made it. Like it is what I always really wanted to do. And that is a really powerful thing. Not a lot of people get to say that. So that really keeps me going. And taking care of myself. Yeah, I think self-care, like taking advantage of when I leave the office, before I come into the office, during the weekends, like just making sure that I am taking care of myself as a person and not just as a therapist.
Awesome. And then the same question over to you, Nick. Um, how do you keep that flame bright?
I'm nosy. Um, so it's one of those things where firstly, it really does feel like a calling. It feels like my work is meaningful and is making a difference. And the patients that I do see changing and leaving my care, I'm very proud of them and to a degree proud of myself for helping them along that. However, one of the things that I had to learn how to do was how to accept gratitude from my patients. Because we're often taught when your patients say, "Oh my gosh, thank you for the work we do," you're supposed to kind of return it back to them and say, "No, no, you do all the work in between sessions. I'm just here for the hour." And I kind of got into the rhythm of just not accepting the praise that I was getting. I even talked to my own therapist about it, that's a well-kept secret. Therapists have therapists too. And when we got into it, he said, "Well, Nick, why don't you write down the cases that go well? Why don't you write down the things that people tell you that are meaningful to you?" And I found that once I started, I still tell them, you did the hard work, but I also accept the thing that they're telling me too, which is like, "You're doing a good job. I've never had a therapist like you. You listen so well." And so being able to accept that both positive and critical feedback from my clients helps me become a better therapist. And it also reminds me why I'm doing the things that I'm doing. In moments where I'm having a really tough case, a very resistant client, when I'm just having a bad day, I like to think about the patients that I discharged, the ones that we really connected and really had a lot of success in a very short amount of time. And I point to that as tangible evidence that, yeah, I'm doing the right thing. I look at my caseload and say, okay, right now I have a caseload of about 50 plus people. If I really were to break it down, maybe 5 to 10 of those are what I would consider tough patients. The rest really are enjoying therapy, are really showing progress, are really motivated to be under my care. And as with anything, we tend to pay attention to the criticisms more than we pay attention to the praises. And so just shifting perspectives a little bit and reminding myself, like, hey, you're doing a good job. People are improving. People are saying verbally things are going well. That helps me kind of get back into it. But as Andrea said too, as a baseline, we have got to take care of ourselves because if we get burnt out, it's over. There isn't much we can do from that except get us to a place where we're not burnt out anymore.
And I guess how do you know, is it a reactive thing or a proactive thing? In other words, are you thinking about taking care of yourself when you feel that quote unquote burnout, or is it something that you're doing every day because you know that that is important to prevent burnout? And I'll start that question with you, Nick, and we'll go to Andrea.
Yeah, I'll take it a step further and say what really helped me with burnout is expanding my concept of self-care. Self-care isn't just brushing your teeth every day, taking a shower every day, all these other things. It is about full holistic fulfillment. Am I satisfied with my family? Am I satisfied spiritually? Am I satisfied physically? Am I satisfied nutritionally? And really accepting that self-care is an ongoing process that you are constantly maintaining attention to. Because at the end of the day, we ourselves are a therapeutic instrument. We got to make sure those tools are sharp. Also acknowledging that self-care doesn't exist always in blocks of time. Because I have a baby at home, maybe I can't go home and just I use the term my clients use bed rot for hours and play video games and do things like that. I really have to take things moment to moment. So if that means that between sessions I'm reading a comic book, or if it means when I get home from work I'm putting my headphones on and listening to music for about 10 minutes just so I can reset. Even if I'm in the middle of a session and I need to put my feet down and kind of feel the ground underneath my feet to feel more stable, everything when it comes to burnout prevention is moment to moment. And at least for me, it's always kind of in my mind in some capacity.
Awesome. Thank you, Nick. And Andrea, same question to you. Is it more of a prevention thing, or is it more of reacting to how your body or mind, spirit is feeling?
I would say personally for me right now it's more of a preventative thing, like just continue taking care of myself, being proactive with my work, like try not to take any notes home, just to make sure that I'm spending significant time with people at home and with friends during the weekend, with family, whatever that is. Taking time off, like it's okay. A lot of times I'm like, oh, this patient that needs to be seen weekly, like we're not gonna have this appointment, but I'm like, okay, I need to take time off too. So, vacation, like just having some self-care time that like the only thing that you're really thinking of is self-care. Um, as yeah, next just said professional boundaries too. A lot of times I am fortunate that my front desk will ask me if I can take on a new client or not. A lot of the time I will say yes if I feel like I am able to, but some other times I will say no, and they'll understand that because I do need to still continue to give good quality care to the clients that I currently have. And supervision too, like it just kind of like making sure that your supervisor is holding you accountable to not have any unhealthy practices that will lead you to the point of burnout, because of course like supervisors will have more experience with it and using different tools. Like I'm lucky actually that I just got done with this. I completed one for myself. I give it to one of my clients that is a nurse. So this is the, as I mentioned, the professional quality of life scale, and it's for helping professions. So I do this like every 6 months just to make sure that I am in check, that my scores are not too high. This measures for compassion satisfaction scale so that you don't have any compassion fatigue. It assesses for burnout scale and then for secondary traumatic stress. So just doing like these little things that are very preventative to make sure that you're not getting to that point of not coming back.
Awesome. And then what I would like to just actually comment on that as well. We did a segment on some of our high performers on what they do and what makes them really engage in patient care. And I think it was about eight of our high performers, and pretty much the theme throughout is the best way that they engage their patients is, proactively and preventatively helping themselves. And
Mhm.
they view it, and I think that the one person mentioned that was great is they really view themselves as athletes, right? And just as an athlete, eats a certain way and goes to bed at a certain time and trains, they view that the same way because it's very hard to be present in a session when you're tired, or it's very hard to be present in a session when you had a very big carb-filled, sugar-filled lunch and you're sitting down in a chair and you're tired. So they talked about really engagement was bringing your best self to work and really being able to really provide the best care to themselves first, putting the mask on themselves first before they put on their clients. So appreciate your feedback there. Time for probably one or two more questions, and then we'll go to the chat. Um, the question I have really for both of you is, you let's just back up 2 years, right? So 2 years ago, what do you know now that you wish you knew 2 years ago, and what would you do differently? So as you were in your master's programs, what do you know now that you wish you knew, and what would you do differently? And we'll start with you, Andrew. Kind of a hard question, but
Yeah, that's difficult. I would say already what I've mentioned with understanding that you can't work harder than your clients and
Mm,
that we have to meet them where they are. Because I do feel like when I started as a full-time therapist, I was like, okay, I'm doing like all this stuff, like preparing for sessions and like bringing this worksheets and like activities and interventions. And like those are, of course, amazing to like have with the US tools. Um, but this is just like a microsystem. Like your clients leave and then they still have the rest of their week and lives to get through. So they have to put in this the hard work too, of course. Supervision, I also would reinforce that you interview your supervisor as much as someone would interview you for a job. It is a really important relationship to have, and it is really important for you to connect with your supervisor and to have that trusting relationship as well, that they will be supportive, but also hold you accountable for continuing education, for good client care. And I would say like supervision, I think it was reinforced in our program, but it is really important. And I've been incredibly fortunate to have an amazing supervisor, which is also why I reinforce it so much. And I will say lastly, um, let me think. I was thinking of something else and it just slipped my mind. Oh yes. So when I went into my program, I was like, I don't want to see any kids. I have no interest in working with kids. It's just not for me. Give me all the young adults, all the adults. That's my thing. And then I came to Elite DNA and they were like, no, like try it. Like my supervisor was like, you should just give it a try. And I did. And now, as I mentioned, I work with all ages. I love working with my kids. This week's theme was making bracelets. Everyone wanted to make bracelets. I probably made a total of 12 bracelets. I'm wearing one right now. It's so fun. It's so rewarding. It's so amazing. Like, yeah, it's hard, especially working with parents. It's difficult. But I guess with that, is just give everything a try. Like, don't say that it's not your thing until you've tried it, and just really put yourself out there. Even during like your registered intern years, just really try to find what your niche is and don't limit yourself to just one specific population, one specific area of specialty. And it's amazing to have areas of specialty and special populations. I have those too, but don't close yourself to other things that you're just, I guess, predisposing yourself to not enjoy.
awesome. Same question to you, Nick. What do you know now that you wish you knew 2 years ago? What would you do differently?
So this is going to be a strange one. It's actually two things. One is knowing when to give up and knowing when to ask for help. So when I say knowing when to give up, there are certain times where you'll run into a patient that just is not a good fit for you. And very early in my career, I was trying to kind of force fits. And I think most of it was kind of like an ego thing, like, oh no, I can work with any kind of patient, I can do any kind of work. And sometimes it just comes down to a difference of personalities. Sometimes you're just not going to connect with somebody. And there were some patients that I saw for months and months that I think, looking back, I probably would have referred them to someone else within a couple of weeks, or at least within significantly less sessions. Even down to, as Andrea said, supervision. My first supervisor really was not a good fit, and I stayed with them far longer than maybe I should have before I voiced maybe I should try someone else. And it did put me at a disadvantage. So recognizing, okay, maybe it's not giving up, recognizing limitations, knowing when you're kind of hit that wall and you need, and this goes into the other thing, you need to ask for help. There's a big pull because, you're going into this profession and for some of you, this may be your first kind of job where you have an extent of authority. And sometimes that can be a lot to wield, and maybe it's a little unwieldy. So being able to reach out to other people and say, hey, I think I'm a little lost with this person, or hey, maybe this diagnosis could use a little bit of work, or hey, I really just need a very specific intervention, instead of trying to brute force your way into helping a patient, which kind of defeats the purpose. If I'm brute forcing the help, is it really helpful? So I think those were the two things, like knowing where my limitations are and then knowing when to ask for help.
Awesome. Um, let's go ahead and kick it to the panel. I'm sorry, the panel, the chat. I have some questions that I pulled off here that we'll go through. And please feel free if you have a question to go ahead and put that into the chat. And we will hopefully be able to cover all of it. So the first question, and we'll start with you, Nick. The question is there a tipping point in this career we're aspiring to that makes or breaks our entry into it? or is it integration into a career easier depending on how available it is locally?
Hmm. Can you say that question another way? I'm having a hard time comprehending it.
Who asked that question?
Hi, that was my question.
Oh, awesome. Thank you.
Yeah. Right. So the question is more of like specifically I'm from Alabama
Mhm.
and around here, the kind of I guess gateway of entry into the career is a little vague since like the university I'm at is primarily an engineering university, but it does also offer psychology. And so like a lot of what is available around here is a lot of industrial psychology as opposed to mental health counseling that I'm wanting to do.
Mhm.
So I'm just wanting to know, is there necessarily any aspects of the career that make it very hard to get into it? Or is it more of just like d depending on how available it is near you that it's easier to get into this career?
And you're talking specifically about like just your entry point into the field.
Yes. So like around here there are some some counseling centers. I
Mhm.
go to one myself and they're very small in scale compared to like around here we have Redstone Arsenal that is kind of like so big that it has a dedicated counseling center to itself. And but that's more relating to industrial psychology to a military base than
Mhm.
it is to the general public. So, because of how like skewed it is where I'm studying, I'm wanting to know like, is that how it is everywhere else, or is that more of just the situation I find myself in?
Sure. So I can't really speak for every other state, obviously. What I've typically noticed in terms of like trends is the point there's a demand pretty much everywhere. Every state you go to, there's going to be a demand for counseling and almost certainly a shortage of counselors. If you're noticing around you that there just aren't a lot of counseling centers, that tells me that the demand is probably very high in your area. And in that case, that can kind of almost be a call to action for you. If you wanted to start your own practice, if you wanted to get your own patients in, I think, and again, this is just an assumption because I don't know what the other states look like, but I think in more, let's say, progressive or liberal states, there tends to be a lot more proponents of counseling centers and things like that. And with that, a lot of folks take advantage of that. But I would say there's still a demand in rural areas or more conservative areas. It's just a matter of kind of, as you said, finding that entry point, which I imagine, if I could speculate, if you were a licensed therapist and started your own agency and started your own counseling center in or around a metropolitan area within that specific state, I don't think you would have a terrible time filling your caseload. I think eventually people would find you as long as you're advertising in the right spaces. I can't think of a particular area of the country where demand would be significantly low. The only thing I could think of, using Florida as an example, if I was to go somewhere like DeLand, Florida, and open a in-person counseling center with no virtual options, specifically serving LGBT populations, I might be hard pressed to find some clients there because a lot of them are going to be more located toward the metro areas. So I think the target population is also a factor. If you're thinking about going somewhere like Alaska, really understanding that population and how you're going to serve them best, or even in your home state of Alabama, what's in high demand? Where are the gaps in services? And where can I help meet those gaps? And that can also just be a conversation with local agencies and saying, hey, do you have a lot of business? Do you not have a lot of business? Is there not a high demand for it? And that can maybe help answer the questions in more of an answer, or answer the question of demand in more of like a local capacity.
And let me just add to that too. And one of the things that we do for individuals who join us, especially newer to the field, our goal is really to make them as marketable as possible. And the only way to do that is working with a larger age range, right? Andrea talks about she now works with all ages, having done her internship with us, whether that's 13 and up or 6 and up or whatever it may be. And we also provide a ton of training. So whereas a lot of people may feel comfortable coming in and working with maybe anxiety and OCD, our goal is to really wrap around and support them through trainings that we have to make them as much as a generalist. I know there's certain populations that they prefer to work with or really are passionate about, but giving them the tools to work with as many people as possible. So if they do go off and do their own private practice or do their own thing, wherever it may be in the the 50 states here, they can do that and they can be successful because they know that they'll be able to have a full caseload. I've been asked the question separately, and I'll just put it out to everybody here. Marianne is with us. She's one of our fantastic recruiters, and we are looking for. The question was, are you hiring? So we are hiring for master's level therapists, both in person across our 36 locations in Florida and one in Virginia, but also for remote positions as well. So Marianne's going to go ahead and put her email into the chat, and so feel free to reach out to her privately if you're interested in positions or learning more about the organization, and she could provide that information to you. The next question we have, and I'll send this over to you, Andrea. Camille wants to know is she currently struggles with laughing at inappropriate times as a coping mechanism, and I'm nervous about laughing at a client. What are some ways to maintain decorum and professionalism? Great question.
Yeah, that's a good question. I feel like that's probably something that I asked myself when I was first starting to see clients, and it's really valid. I would say first and foremost, you are a human. Like we are gonna have human reactions to certain things. But we also are supposed to abide by certain professional and ethical standards. So I would say, just this is a very like hard question to answer specifically because it just really depends on the context. So it depends on like the type of things that you're laughing about, right? Like if a client is making kind of like a dark humor joke of as using it as a coping mechanism, it's like, oh, I'm just gonna go leave and like jump out of a bridge, and like you laugh at that, it's probably pretty inappropriate, right? There's some other things that people are funny sometimes. Like that's just their personality. They're funny, and that's okay. Like we're not robots. I think that would probably really put people off if you're just there with like monotone facial expression. So I would say utilize context and you utilize like your own like clinical judgment to see what is appropriate and not. I would say it would probably put teens off if you never laugh with them because you are a human still. And then additionally with that is being comfortable with silence. I think a lot of times like if you're nervous and like you're nervously laughing, it's probably because you're not fully comfortable with silence yet. And a lot of people don't realize how important that is in counseling and as a therapist, to just be comfortable with letting them take some lead of sessions sometimes too, and not just use your own laugh as a coping mechanism.
Andrew, how do you get better at being comfortable in the silence?
Exposing yourself to it. Yeah, we tell our clients to be uncomfortable all the time. Like if you're too comfortable, you're probably not doing something right. So just doing it as much as you can, and then you're going to realize at some point that it's not going to be the end of the world. And sometimes it's very much needed for the client, but also for yourself. So just do it. I'm sorry, that's probably a silly way of answering that question, but it's just exposing yourself to doing it.
No, that's great. For you, Nick, Mariana wants to know, is there ever a moment during a session where you don't know what to do, what to say, or what the best approach is? If so, how do you deal with that at the moment when it happens?
So I'm gonna steal Andrea's answer. You don't say anything. One of the biggest things that I had to realize when I was first starting in this career is that you get to a place where you don't know what to say. Once you get further along, you can kind of figure out where to go and you kind of enter your flow. But when I was first starting out, there were several moments like that where I did not know what to say. And the worst thing I can do is just react without thinking. Be like, oh, well, did you try this thing? Oh, and it can very much seem like, okay, this guy's throwing stuff at the wall. I just sit there in silence. I'm like, hmm. If it's really something so astounding to me that I really can't respond, I may even say that. I'm like, I'm lost for words. I don't know what to say in this moment. Being honest about your reaction in that way can be very helpful and very freeing too. Also, realizing with that therapeutic use of silence, and this is something that Andrea and I learned when we were very first starting out, the period of silence always feels longer than it actually is. So when you're in the moment and you're quiet, it may feel like, oh my God, I haven't said anything in 3 minutes, and it's been like 5 seconds. give yourself some time, give yourself some grace, understand that the words will come as you become more familiar with your modality, more familiar with the patient, and just more familiar with the profession. But even today, there are days where I don't know what to say, and I'll just kind of sit there. Or maybe I'll just put it on the patient. I say, okay, what do you want to do about that? Like, you've told me this thing, where do we change? Or I'll just ask a question. How did that, as cliche as it sounds, how did that make you feel in the moment? What would you do differently? Sometimes it helps to kind of put it back on them and just let them explain a little bit more, because it'll give you more context, and honestly, it'll give you a little bit more time to think about what you want to say.
And this is actually for both of you. Do you have any recommendations, um, book recommendations or movies, documentaries, that were pivotal in your journey towards becoming a counselor?
Okay, I'll let Andrea go first. I'm going to grab my books real quick.
Ugh, that's hard without my books. Let me think of a couple, and I don't know if you can take note of this while I say it, but I will say The Buddy Keeps the Score is a really good one. I would say probably if you ask 90% of therapists, they've read that book. I recently started, it's called Polysecure. So it talks about polyamorous relationships, which is I don't know if maybe it's just a population that I work with, but it has been like a trending relationship dynamic. So that has expanded my horizons in that sense. Let me think of what else recently. Oh, I read a couple books by Irvin Yalom. He is big in group therapy, and he's actually a really good author. I love reading, and he writes fictional books as well, like a little bit more of like, of course, like psychological, maybe thrillers, but also like historical fiction too. So that's really good from just like a better understanding of like person-centered approaches, I guess. Um, Let me think what else. I have a couple ones. I read the Orange Book of Schema Therapy. It's just called Schema Therapy, but there's a lot of schema therapy books. So I know that is the orange one. What else have I read? And oh, I recently just read an amazing book. It's called The Wretched of the Earth. It's a book from like like 1962, but it talks about mental health disorders and how it's impacted by colonization, which I think is super relevant, which what's going on in the world right now. So I know that's a little bit of all over the place, but if I could look at my home library, I could probably give you some better ones, but maybe Nick can take over.
Sure. So, someone asked about documentaries. The one documentary that I will absolutely recommend is, I forget who it's by, but it's a documentary called The Work. It is a film about a group therapy program. It's an intensive 3-year, 4-day experience where they take prisoners and folks from the general population, put them together, and do an intensive group therapy experience. Oh my God, that changed the way I look at group. It is so powerful. It is so impactful. It is an incredible film with real people having real dramatic experiences and transformative growth. And I love it to death. Highly recommend that. The 3 texts that really changed the way I look about therapy. So, Man's Search for Meaning by Viktor Frankl is a huge one. This really, really, really changed the way I thought about the power of hope. It's really not so much the interventions itself, it's the belief that things will get better that really transforms into transformative growth and getting people out of their slumps. The second book I'll recommend is Forward Facing Trauma Therapy by Eric Gentry. It has a lot of great techniques. It's kind of organized as a self-help resource, so you can recommend it to patients. The techniques in this book, I cannot undersell. I just started using this stuff, and now my patients are doing phenomenally better than when I was just relying on cognitive strategies. If you compare or if you combine this with something like CBT or RABT, you will have tremendous results. The third thing I will recommend as transformative to my kind of conceptualization of therapy is The Manufacturing of Madness by Thomas Szasz. Thomas Szasz is a psychiatrist who was alive in the 1950s who hated psychiatrists, which which really does it tells you something. I'm someone who loves this field with an intense passion. However, I'm very critical of it too. I think there's a lot of changes we can make and a lot of ways that we can improve. He goes into depth of essentially the concept of either you agree with us and say that you do have a mental disorder, or you saying that you don't have one just certifies that you still have one. And so it kind of contextualized how we view mental health, how we view mental illness, and really just kind of cements it as maybe these aren't really pathologies at all. Maybe it's just differences in personality, differences in brain that we've just deemed as acceptable or unacceptable. Um, don't follow this like it's the Bible, but take some of the stuff out of it that lets you really be critical of the field and ask those important questions.
Sorry, I'm gonna interject super quickly, but yes, I would say men's search for meaning is life-changing. So add that one, and also I forgot, but Building a Life Worth Living by Marsha Linehan. She's the creator of DBT, and that's a really, really good one. I think as Nick, like I appreciate like a little bit of like the history telling and like personal telling, and then like matching it with our profession and clinical work. So yeah, I just thought of that, and amazing, Nick. I love that book.
As a non-clinician, but somebody from the business side, Viktor Frankl. If you haven't read anything by him, absolutely incredible story. And so, same thing with Marsha Linehan. I am, like I said, not a clinician, but if you actually know her story, a lot of you are familiar with the modality, but if you actually know her story and how she came to create
Yeah.
um, said modality, you would be truly amazed. Two incredible people. Time for, I think, one more question. This is actually going to go to you, Nick, just because you mentioned earlier that you had changed qualified supervisors. So the
Mhm.
question is, if you don't fit with a supervisor, how do you go about getting slash finding one? Is it one of those things where, you kind of approach them, it's me, not you kind of thing, or how do you go about having the conversation, but then also finding another qualified supervisor?
So it can be a couple of different ways. Outside of this particular organization, I can imagine that it goes through kind of the painstaking process of going on Psychology Today, finding someone who is a qualified supervisor, messaging them to see if they're taking new people, seeing what their rates are, comparing rates to your current supervisor. And then it's a matter of just facilitating that transition. Your old supervisor has to send a letter to the board saying, hey, I'm no longer with this person. And the new supervisor has to say, hey, I'm taking on this person. And you want to coordinate it in such a way that you're not without supervision for more than a week because from what I've been told, if you're going to be audited on your hours and things like that, supervision is the one that's most often audited. Within our organization, though, it can sometimes just be a conversation versus a conversation with your current supervisor and saying, hey, maybe we can try doing these things a little bit differently. I tried that route with my supervisor, but even after those changes, it still wasn't quite the connection I was looking for. And then it just turns into kind of approaching leadership together, hopefully collaboratively, and saying within this company, hey, we need to be placed with a different supervisor. I believe, if I'm remembering correctly, our regional therapy lead helped coordinate with a new supervisor that was just trained up as a QS, and then they positioned me with her instead. So in terms of internally here, it was actually a very seamless process. Externally, I can't really say how cumbersome it would be, but it is a fairly simple process from what I understand.
And one thing, just to clarify, for those who have not graduated, when you do graduate and want to work towards your licensure, you will need a qualified supervisor. It's important to find an employer that hopefully provides that to you, hopefully for free, because there is generally a cost. Some supervisors will charge as much as $100 a week, and you're in supervision for generally about 100 weeks. So that's almost $10,000. So I would definitely, as you're interviewing or looking at positions, find out, is qualified supervision provided, free of charge, or is there any supervision that can be provided? We are just about out of time. I do want to thank the panel. I'm always so appreciative for the insight that Nick and Andrew bring, and I know it's been a busy day. They've had, tons of clients, have done some incredible work. So I appreciate them jumping on and providing their insight, and really, really thankful to them. Also want to thank, Christina Johansson, who's the Elite University person who puts this on all together. So really thankful for her, and for Marianne, who are a fantastic recruiter who also helped organize this. As this meeting comes to an end, you won't have access to the chat. So I do recommend, if you do want or have some questions on employment or any other questions, to go ahead and take the picture of Marianne's QR code, and that will give you the information you need to contact her. And I appreciate every single person who joined. There was some great feedback that I've gotten in the chat privately and in the main chat. And I'm glad that you've taken the time out of your Thursday. And I hope this was extremely helpful to you. So thank you to everybody, especially our panel, but for you all for joining as well. Have a great, great rest of your afternoon.
Thank you.
Thank you.
Thank you. Thanks, Andrew. Thanks, Nick. Take care.
Appreciate you all. Thank you so much.
Thank you.